we're going to move on to our debate series, and we're going to ask Dr. Henao to come up and get in a fight again. But first, I want to poll the audience, because I don't think these debates really do anything if we don't know what the current climate is. So for those of you in the crowd, please raise your hand if you think it's perfectly acceptable to treat a 1 centimeter infrarenal neck with just standard EVAR. How many do we have? We have 1, 2, 3. Okay. And how many of you believe that we should treat a 1 centimeter infrarenal neck with fenestrated EVAR? Okay. 1, 2, 3. 7, 8. Okay. So about 15 people. So now we know where we stand. So
still, there is a third option.
Dr. Henao, you have your work cut out for you.
All right.
We'll hear about it, right?
So here are my disclosures. Let's dive in. So I approached this talk with what I would do. There are other varieties of options that I don't have experience with that I'll go into. But for this particular talk, I have an extensive experience with the polymer ring technology that was with Trivascular and got acquired by Endologics years ago. This is some of the earlier data that showed no aortic neck growth from a multi-center registry back in 2016. So now we're talking about something that's already about 10 years old, and essentially this is now an old model, which isn't really that applicable, but I'm going to focus more on the technology of the ring itself, that singular O-ring that you might see in a sink or a rocket. And so it is a engineering principle, basically, on how you stop something from leaking, as opposed to a traditional model where you've got wire and fabric and a zone that expands with radial force to kind of shut leaks down. So the Alto system that I prefer in general for all of my cases now has an indication of 7 millimeters. And so the question that was posed is this safe or is this effective? This is a modular bifurcated device. It's a 3-piece system, completely percutaneous, and is deliverable, and skin to skin should be done in about 45 minutes. So it's a great rupture kit with an incorporated balloon, but also for short necks, also for tortuous iliac anatomy, just to deliver to the target. There's other qualities about it, including difficult and hostile neck anatomy that may be laden with cholesterol, plaque, calcium, because the actual final manufacturing process, if you will, is when you inject the polymer and it cures after about 14 minutes. It molds itself to the inconsistencies of the neck and gives you a true seal. The other thing is, because it's such a low-profile system, it's very broadly applicable to pretty much any patient that comes in. As we saw earlier, the female affected with abdominal aortic aneurysms is a very dangerous pathology, and just being able to deliver the system is a feat in itself. This comes from the M2S database, where the traditional type grafts have a bit of a weakness in being able to fit the bill in terms of anatomy, whereas the complex things such as a fenestrated device or a device that requires the endo anchors may be a little bit different. But again, the question posed is, do all sub 1 centimeter necks need to have a Z-fin? And so I think that's why this is a very compelling debate. Here's a little bit further into the neck length indication and the vessel access parameters. Again, having a small device that's very maneuverable with a 7 millimeter neck indication, if you don't have this on your shelf when a rupture comes in and you don't have time to, or maybe you don't have a crew that can do these incredible PMEG devices or whatnot, which I think are extraordinary devices, but I'm trying to move this conversation to the average Joes among us that do vascular surgery, and maybe we only do 10 or 15 AAAs per year. what are you going to use? So this is still kind of half-baked, the Jaguar study. I don't know if you're familiar with this. Sean Leiden presented this in Europe back in February and was basically giving us a preview of coming attractions where there is some, slightly higher type 1s and maybe type 2s at the 30 days with the Alto group. But given time, most of these resolve. The key here is in the stability that the polymer may confer on the neck and thus limiting movement of the device over time. Again, this was what I alluded to earlier. There's the Endurant plus endo anchor system, which I'm not necessarily something that I'm for or against. It's just I don't do it. So the question here is, all infrarenal AAA with 1 centimeter or less should undergo fenestrated stent grafts. This is such a hyperbolic statement that it's impossible to win this debate. I'm sorry, but good luck. Standard endografts, again, lots of benefits, but ultimately, with a simple device like this, lower cost, more widely available, more deployable, and more likely technical success for those mere mortals that can do these types of devices without having to, struggle with all the radiation exposure that Dr. Ramaiah just mentioned. And the biggest issue has to do with a fenestrated stent graft and the manipulation of the renal anatomy. That's a huge deal, just from a medical legal standpoint. If you were going to push this debate to, yes, you should do this on every sub-1, lawyers would just start seizing with the excitement of what that would mean for their careers. 16% risk of problems with the renal function or pre-existing renal function will hurt the kidney. 39% risk in patients with baseline renal insufficiency. Again, it's not to say that you aren't going to see that with just a conventional EVAR, but we're talking about a dramatically reduced risk of that. Not to mention, FEVAR is a custom build. I'm not talking about PMEGs, because that wasn't what this debate is about. Inadequate iliac artery anatomy. FEVARs require, relatively speaking, a giant delivery system versus a 14 or 15 French device. Severe calcification and thrombosis that can complicate the landing zone of the wire and fabric versus what I described as the custom seal of this Alto device. The FEVAR requires extreme precision, and it may not be suitable for not necessarily the operators, because I know that we're well-trained people, but you're working with people that may come and don't even know what an indiflator is or how to work the power injector. These are practical things that hurt us in the real world. And then obviously the longer procedure times that can affect anesthesia and radiation. So I'll kind of steal Occam's razor here. The simplest solution that adequately addresses all aspects of a problem will indeed be the best choice, usually. And with that, I will yield to my competition here.